Hi, I'm Terry Kratzer. Welcome to another TrisomyTalk.com webinar. Today's topic is one that is relevant to all, but especially so to parents of a child with a trisomy diagnosis. Today we will be discussing constipation. Our speaker, Ann Barnes, is both a registered nurse and a soft parent. She is the co-author of the newly updated book, Care of the Infant and Child with Trisomy 18 or Trisomy 13, which is available for download at trisomy.org. Anne maintains a soft surgery registry. She and her husband Frank sat on the SOFT board of directors for many years, and they continue to serve SOFT through ongoing development of SOFT's website and support to our families of a child or a loved one with a trisomy diagnosis. But beyond all of this, and most importantly, Anne is Megan's mom. So to help expand our knowledge and understanding of constipation and how it relates to our children with a trisomy diagnosis, let's go out to North Carolina to Ann Barnes. Ann, over to you.
Thank you, Terry Kratzer, for providing soft families with Trisomy Talk webinars. What a great use of technology. Terry, who so nicely introduced me, is the mother of 14-year-old Chrissy, who has trisomy 18, and she invited me to talk about constipation, a common problem for those with trisomy 18, 13, and many with related disorders, too. The presentation follows, but be forewarned, it contains more detail about your bowels than you ever wanted to know. It was our beloved daughter, Megan, who survived almost 20 years, that brought us to SOFT in 1987, where we met and still continue to meet other families who share about living with their children with trisomy 18, 13, and related disorders. Like Megan, who was born with trisomy 18, these children teach others about their specific syndrome and care needs through their parents. Megan never had a surgery for her bowels. However, she still needed help to maintain regular bowel function throughout her life, and she benefited from the long-term care of a pediatric gastroenterologist and the nutritionist who worked with him. As Terry said, my background is in healthcare, primarily as a pediatric registered nurse, and I also earned the title of stay-at-home mom during those years when our 3 oldest children were young, plus the years prior to home health care for Megan, our youngest. So this talk about constipation is presented from the perspective of being a mom who has been there, and as a nurse with insight gained from other SOFT families and also the SOFT surgery registry. This information is not a substitute for your doctor's advice. Any ideas that interest you should be discussed with your child's healthcare provider as to the appropriateness for your child. This slide shows what will be discussed in this presentation. What is constipation? Constipation is a common problem for the general population of all ages, so common that doctors generally prescribe laxatives without testing for possible reasons. In the USA, constipation accounts for 5% of pediatric office visits and 25% of referrals to gastroenterology specialists. But the incidence of constipation for children with neurodevelopmental disabilities is 74%, much greater than the general population. At one of the early SOFT conferences in Rochester, New York, Dr. Gregory Liptak, neurodevelopmental pediatrician and the physician who took care of one of SOFT's well-known long-term survivors, described constipation as a delay or difficulty in passing a stool for 2 weeks or more, which is a description that likely encompasses all SOFT children and quite possibly many listeners of this presentation. Be aware that chronic constipation is a symptom of an underlying problem. Understanding the challenges and causes could help find relief for your child. Children with trisomy 18, 13, and some with related disorders have problems related to intake of nourishment and output of stool. Coordination of muscles used to suck or chew, swallow, and breathe affects intake. Feeling the urge to go, bearing down with abdominal muscles to push, and relaxation of pelvic floor muscles to let stool out affects output. Constipation occurs when stool accumulates in the rectum and becomes dry, impacted, and/or difficult to expel, which may lead to 3 or more days between bowel movements. Normal frequency of bowel movements in a healthy newborn is 2 to 3 times per day, decreasing with age to once daily for those greater than 3 years old. Small firm stools, appetite decrease, and fretfulness are some of the signs of constipation, and loose stool or diarrhea may be a sign of stool moving around in impaction. In most cases, constipation is diagnosed as a functional constipation, which might be of short duration with treatment and behavior modifications, but can reoccur or become chronic. A functional disorder refers to an altered way the body functions, not caused by abnormality or illness. Only 5% of constipation cases are due to anatomical or organic causes for the population in general, but for those born with multiple anomaly disorders like trisomy, the incidence might be greater. The Soft Surgery Registry lists numerous kinds of surgeries involving the bowel for those with trisomy 18-13 and related disorders. The lower digestive tract consists of the small and large intestine and the rectum. In this slide, the faded lines connected to the bottom of the stomach show the beginning of the small intestine. The small intestine mixes digestive enzymes with food residue and absorbs nutrients. It ends at the cecum shown in the slide, which is the beginning of the large intestine. The large intestine is also known as the colon. Nourishment moves from the stomach to and through the small intestine to the beginning of the large intestine called the ascending colon. The undigested nourishment residue then moves up the ascending colon, across the transverse colon, and down the descending colon to the rectum. The small intestine is called small because its diameter is less than the diameter of the large intestine. However, on average, the small intestine measures 3.5 times the length of an adult person's height. The large intestine, also known as the colon, about 5 feet long in an average adult, is a tube-shaped muscle. Short segments of this muscle contract to move food residue back and forth for water extraction. Periodically, strong contractions begin in the ascending colon and move progressively, pushing food residue towards the rectum. If these strong contractions fail to occur, it causes slow transient constipation, STC. The slower food residue moves, the drier it becomes. Before moving to the next slide, pay attention to the location of the rectum and the anus, bottom center of the lower digestive tract. This diagram is a close-up side view of the rectum and anus, showing the pelvic floor muscles, highlighted in pink. These are the muscles that must relax to allow a bowel movement. If these muscles pictured in the slide fail to relax, then pelvic floor dysfunction, also called outlet dysfunction, occurs. Anorectal manometry testing can be done to evaluate constipation. There are numerous causes of constipation. Listed in the slide are causes that might relate to a child with trisomy 18 or 13. Inadequate fluid intake or dehydration is likely the most common reason for constipation in all persons. For those with trisomy 18 or 13, feeding and fluid intake problems and tolerance issues with volume make it difficult to be adequately hydrated. But a word of caution, if there is a possibility your child is in heart failure or being treated for heart failure, check with your doctor before attempting to increase fluids. Research results from a survey of nearly 10,000 adults published in the American Journal of Gastroenterology in May of 2013 found that low liquid consumption remained a predictor of constipation. The activity level of those with full trisomy 18 or 13 is insufficient to help prevent constipation, and laxatives are needed. Low muscle tone or motor abnormality affects GI motility. It is hard to push out a stool when lying on your back. Sitting upright on a potty chair helps when bearing down for a bowel movement. Those not yet old enough for a potty chair can be aided while lying on their back by flexing their knees to the chest and giving a little pressure to the soles of the feet. My daughter Megan began using a special needs potty chair when 3.5 years old. Routine timing for sitting on the potty chair after feeds and sleep, along with a lot of praise, resulted in 75% voiding and 80% bowel movements on the potty with success. Be aware that drugs can contribute to constipation problems. Drugs for reflux, seizures, heart failure, pain, supplements of iron or calcium, and many anticholinergics, which dry secretions and slow digestion, list constipation as a side effect. Ask your doctor about possible side effects and interactions of all the medications your child takes, even those taken by nebulizer. Do not discontinue or change a medication without talking to your doctor. Misuse of laxatives can cause electrolyte abnormalities, such as excess calcium or too little potassium, which contribute to constipation and possibly other health concerns. Laxatives will be discussed in more detail later in the presentation. Lack of strong colon contractions result in slow colon transit, or SCT. An early symptom of SCT is delayed passage of meconium, dark sticky stool, beyond 24 hours of age in the newborn. A nuclear transit study can help confirm suspected SCT. Care is managed with laxatives and/or enemas and careful diet under the long-term guidance of a pediatric gastroenterologist. But if there is no improvement, then surgery such as colon resection, colostomy, or cecostomy might be considered. These surgeries for children with trisomy 18-13 and related disorders and numerous other reported GI surgeries for abnormality or blockage can be seen in the soft surgery registry at trisomy.org. For example, colostomy has been done in 4 children with trisomy 13 and 3 with related disorders. Cecostomy, which we'll discuss later in this paper, was done in 1 child with trisomy 13. Intestinal resection was done in 9 children with trisomy 13 and 5 with trisomy 18. Of these, 3 with trisomy 13 specified that it was a colon resection. Outlet muscles failing to relax cause pelvic floor dysfunction, or another name for it is outlet dysfunction. Dysfunction occurs when an urge to have a bowel movement is felt, but the pelvic floor muscles fail to relax or tighten instead of relaxing. Supporting your baby in a warm bath might relax the anus and produce a bowel movement in the bath. Stimulating the anus gently using a lubricated, old-fashioned rectal thermometer is another suggestion you can ask your doctor about. Technology provides a number of tests to confirm a dysfunctional diagnosis. An anatomical malformation of the anus contributes to difficulty having a bowel movement. A malpositioned or funnel-shaped anus was found in 10 to 50% of cases of trisomy 18 studied by Jones in the well-known medical genetics textbook, Smith's Recognizable Patterns of Human Malformation. Multiple anomalies of every organ system have been noted in Jones studies of children with trisomy 18 and 13. However, an infant may be born with several anomalies, yet another with only a few. The soft surgery registry shows anoplasty was done on 6 children with related disorders, 1 child with trisomy 18, and 1 with trisomy 13. Rectum reconstruction was done on 1 child with mosaic trisomy 18. Fear of having a bowel movement happens when a child experiences pain with a bowel movement or anxiety, as might occur when potty training. The urge to have a bowel movement happens when nerve endings in the rectum detect fullness. The child who fears a bowel movement can tighten the anal sphincter muscles and withhold the movement. This exasperates the problem by backing the stool up and stretching the rectum with accumulation, and the urge sensation dulls. The stool sits longer in the rectum, continues to dry, becoming more difficult to pass. There's a medical term for this. It's called functional fecal retention. Certain foods such as cheese, bananas, rice, whole cow's milk can contribute to constipation. For infants, a transition from breast to formula often begins constipation issues. The child's health provider or nutritionist can provide information about formulas, foods, and constipation. Comorbidities are possible coexisting conditions and diseases related to constipation. Hirschsprung's disease occurs when some of the nerve cells in the intestine are missing or do not form properly during pregnancy. The missing nerve cells interrupt signals from the brain telling the walls of the intestine to move food forward, known as peristalsis. These babies are unable to have normal bowel movements, are constipated, and develop partial or complete blockage of the bowel. 25% of intestinal obstruction in all newborns is caused by Hirschsprung disease. Delayed passing of meconium, the dark sticky stool in the newborn, in the first 24 to 48 hours of life is a major symptom. 80% show symptoms in the first 6 weeks of life, but if only a short segment of intestine is affected, the child might not show symptoms for months or years. Symptoms in the older child mimics other illnesses. Constipation gets worse, loss of appetite, delayed growth, and small watery stools. Testing is done by X-ray and barium enema and biopsy. Treatment depends on the extent of the problem, but if bowel obstruction happens, a surgical bowel resection, removal of the infected intestine, and a colostomy is usually necessary. With a colostomy, the end of the remaining healthy intestine is brought through an opening in the abdomen. Stool will pass through the opening into a bag. This might be temporary or permanent. Hirschsprung's disease has been reported by a few soft parents. Find more information about Hirschsprung's at trisomy.org under Resources. Meckel's diverticulum is an outpouching or bulge in the lower part of the small intestine, also called MD. MD is the most common genetic gastrointestinal GI anomaly at birth, affecting 2 to 3% of the population, but it is not a problem for most and does not necessarily need treatment. Symptoms usually occur in the first year of life, but can happen in children and adults. MD can secrete acid and cause ulcers and bleeding. Bowel obstruction is possible, occurring more often in older children. If bleeding, abdominal surgery or laparoscopic surgery can remove the diverticulum and the intestinal ends are sewn back together. MD has been reported by a few soft parents. It is noted in Smith's recognizable patterns of human malformation as occurring in less than 50% of persons with trisomy 13 and 10 to 50% of those with trisomy 18. For more information about MD, go to www.trisomy.org under Resources. Neurodevelopment disability or neurological impairment of the bowel affects GI motility and a person's awareness of urgency as well as their brain and gut response. Spina bifida occurs in less than 10% of those with trisomy 18 and less than 50% of those with trisomy 13. A neurogenic bowel has loss of normal bowel function because nervous system impairments cannot tell the brain when it is full, resulting in slow peristalsis. Hypothyroidism can be detected by newborn screening, which is mandated in most states, or if a child develops a symptom when older, by blood draw. The incidence of hypothyroidism is 1 in 4,000 newborns. Symptoms include slow pulse, excessive sleep, and constipation. Recently, two soft mothers reported a diagnosis of hypothyroidism in their child, one with trisomy 18 and the other had mosaic trisomy 18. And a few others have commented on Facebook that their child is being treated for hypothyroidism. And finally, illness. Any illness that causes nausea, vomiting, fever, poor appetite, fatigue can contribute to dehydration. Common associations are other health issues that might be related. Gastroesophageal reflux, GERD, G-E-R-D, can happen due to increase in abdominal pressure from constipation. Discomfort interfering with appetite and sleep results in poor weight gain and irritability. Slow gastric emptying can be related to laxative abuse. And of course, cramping, which I think everyone has experienced at one time or another. Possible complications listed below these complications need the care of a medical provider. Pulmonary aspiration related to GERD, anal fissures from straining to push out hard stool causing small tears and bleeding. Megacolon is a stretched colon filled with stool which decreases the urge sensation. Volvulus is a loop of bowel twisted on itself which may result in necrosis, actually cutting off the blood supply to a part of the bowel and or bowel blockage. And fecal impaction. And copresis is a soiling of the underwear or diaper when stool seeps around an impaction. Seizures. If your child has seizures, an increase in frequency can be a symptom of constipation. Urinary tract infection, UTI, can be related to constipation. 25% of girls with UTI have constipation issues. The bladder and rectum are in close proximity. A full distended rectum presses on the bladder, preventing the bladder from filling as much as normal and also interferes with the bladder emptying completely. Retained urine is a predisposition to urinary tract infection, or UTI. Vesicoureteral reflux of the retained urine in the bladder backing up through the ureters into the kidneys could eventually damage the kidneys. Treatment goal and common types of laxatives. The goal for those with trisomy 18 or 13 is to soften the stool so it becomes painless to pass. It is important to learn about the common types of laxatives. The following 6 slides will discuss the laxative types listed below in more detail, including will be 3 hyperosmotics that are likely used by soft families. Some laxatives are available by prescription only, but more are over-the-counter products. A number of them are mentioned in this paper, but not all. Ask your child's health provider about any laxatives you're considering using for your child, even over-the-counter products. They all have the same purpose, but work differently and have possible side effects. Laxative types, 1 of 6 slides. Bulk-lowering fiber supplements must be given with extra water or they will be counterproductive, causing gas, discomfort, and worsen constipation. The fiber fluffs up with water, making the stool softer. Fiber supplements such as malt Supex for infants less than 4 months old and Benefiber for older children are used for mild constipation and considered safest for long-term maintenance, but can interfere with some medicine absorption. These products are not a good choice for those who have difficulty taking adequate fluids. Persons who have intestinal strictures or possible adhesions from a prior surgery should let their healthcare provider know and discuss possible risk before using fiber supplements. Stimulant laxatives irritate the walls of the small intestine and colon. This causes the muscles to contract, propelling contents forward, but may cause diarrhea, dehydration, and loss of electrolytes. Stimulants usually contain sienna, such as seen in Senecot, or cascara, found in castor oil, that occur naturally in some plants, or contain biscadol, as is found in Dulcolax, which is a product that evacuates the colon but has no action in the small intestine. Stimulant laxatives are considered the harshest of laxatives and are for occasional use. or if a child becomes impacted for disimpaction. Stimulants may stop working if used daily or damage the colon, making constipation worse, and are not recommended for long-term use. Stool softeners contain glucosate, which is a wetting agent that allows water and fats to get into the stool. Colase is a stool softener that does not force a bowel movement, but may take 1 to 2 weeks of use for effect. Stool softeners are commonly used to soften stool temporarily, such as after surgery, childbirth, or for occasional constipation. But a note of caution, do not use stool softeners with mineral oil or certain medications. Lubricants grease the stool to help it slip through the GI tract. Mineral oil is a commonly known lubricant, but its use is not recommended for infants and neurologically impaired children, as it is associated with aspiration and lipoid pneumonia. Osmotic laxatives are considered safe for long-term maintenance. Osmosis is a movement of fluid through a semi-permeable membrane from a low solute area to a high solute area. There are 2 kinds of osmotic laxatives, saline and hyperosmotic. Saline laxatives contain non-absorbable ions that remain in the colon and draw water in by osmosis, softening the stool. The most commonly used, milk of magnesia, has a chalky taste and might alter electrolytes or interfere with certain medications. It is used for occasional constipation. It should be used with caution in infants and anyone with kidney impairment. Lactulose is another hyperosmotic. This prescription drug is a man-made, non-absorbable sugar that draws body fluid into the colon, lowers pH, making it an acidifier, and increases bowel movements, but it can cause gas, bloating, and abdominal discomfort. It is for short-term use in those greater than 6 months, and it is one of the commonly prescribed laxatives considered safe for children under 2 years of age. My daughter Megan took lactulose in her early years. Another hyperosmotic, Pedilax, formerly called Babylax, is also an anal rectal irritant. This over-the-counter product is a liquid glycerin suppository provided in a short tube applicator. Insertion of Pedilax irritates the anal canal, draws water into stool, and prompts a BM in less than an hour. In my experience, Pedilax glycerin suppositories are more effective than hard glycerin suppositories, and results took only about 15 minutes. It is used for occasional constipation of 2 to 5-year-olds. If under 2 years, check with your doctor. Babylax was effective even when my daughter was much older. Dr. John Carey, medical advisor for SOFT, advises all parents to check with your child's doctor before using Pedilax. Another hyperosmotic, Miralax, contains polyethylene glycol, PEG 3350, and it is available with or without electrolytes. Miralax without electrolytes is discussed here as it is considered the gold standard of treatment for children with constipation, and that is a personal message from Dr. John Carey. It is a tasteless powder, easily mixed with water or juice, making a high solute solution, and does not cause tolerance. Tolerance means the need for increased doses. A recent article by Walia in Practical Gastroenterology describes PEG 3350 without electrolytes as absorbable in only trace amounts with a very low risk of electrolyte imbalance. This over-the-counter product for adults with occasional constipation and medical procedure has been prescribed off-label to children for more than a decade. If your child has a history of kidney disease, bowel obstruction, or irritable bowel, let your child's health provider know before using this product. My daughter used Miralax with success in her teens. Recently, an alarmist ad about Miralax raised concerns with Facebook moms of children with many trisomy conditions, and one soft mom shared that her daughter experienced dangerous and lasting side effects from increased doses of Miralax prescribed by different GI doctors. Concerns about Miralax, polyethylene glycol, PEG 3350, can be found in news articles, ads, and consumer complaints to the FDA. You can check the FDA.gov website. The FDA scrutinized this product for neuropsychiatric events and made a decision in 2011 of no action necessary at this time based on available information. Walia et al. Notes that the therapeutic safety of PEG 3350 for treatment of chronic childhood constipation and impaction has been demonstrated in many studies. Combination laxatives. There are many over-the-counter combination products for constipation that combine 2 or 3 different acting laxatives, but most contain a harsh stimulant laxative, and long-term use is a risk for possible colon damage. An example is pericolase, which contains a stool softener and a stimulant. Other approaches to constipation. Enemas. There are different types of enema solutions with different modes of action. Enemas should only be used with caution under the guidance of your child's healthcare provider, as enemas can deplete a baby of electrolytes and alter body fluids in children. This is especially true of tap water enemas. Power pudding is a home remedy for constipation that one soft teen is given daily. Dr. Liptak, at his Solve Conference workshop in Rochester, mentioned that power pudding was a mixture of prune juice, bran, Cool Whip, and applesauce. Joe Graydon of People's Pharmacy provides a slightly different recipe in his constipation information for adults. His recipe is mix 1 cup of unprocessed wheat bran, 1 cup of applesauce, 3/4 cup of prune juice, and that the mixture will be very thick and needs to be refrigerated. This high-fiber mixture must be taken with plenty of fluid and used daily. It does not work instantly. Graydon recommends power pudding for adults beginning with 1 to 2 tablespoons daily. If no results in a week, increase by 1 tablespoon. Do not exceed 6 tablespoons daily. So it's a long, slow process. If you wish to try power pudding, ask your child's doctor if it is appropriate for your child's needs and about how much to give your child. Dark corn syrup, or Karo syrup, is a non-absorbable sugar that holds onto water. It is an old remedy for mild constipation in infants, but botulism was a concern in the older product. The current corn syrup product contains less sorbitol, which is less of the non-absorbable sugar. Thus, it is less effective for treating mild constipation in infants, and it is no longer considered a potential source of botulism. However, there is disagreement about the use of dark corn syrup for mild constipation in infants. Natural products are unregulated by the FDA. Thus, ingredients and strength are not monitored. Be aware that herbal teas may contain stimulant-type laxatives and should not be used long-term. Diet and fluids, and I have capitalized fluids there to just bring it to your attention. Consult with your child's health provider or nutritionist about foods, formulas, and enteral products for tube feeding that might help increase stools, and be sure to discuss free water needs, especially if adding fiber to your child's diet. Infants with functional constipation, functional, we discussed early, meaning no organic problem, frequently respond to treatment with juice that contains sorbitol, such as apple, prune, or pear. Most children with trisomy 18 or 13 are tube-fed or partially tube-fed, and baby formulas or enteral formulas for tube feeds are available with or without fiber. Fiber-added Pediasure slowed my daughter's stool output, so we switched back to using plain Pediasure. In hindsight, perhaps she also needed a little extra water. Enteral products for tube feedings contain different amounts of fiber and calorie content. There are more products than in the list on the screen, but you can see there is a different calorie and fiber content per product. Breastfed babies are less likely to be constipated than formula-fed. However, my baby with trisomy 18 was breastfed, but also treated for colic and constipation. Breastfed infants initially stool more often than those who are formula-fed, but breast milk is so nutritious, most of it is absorbed, and these babies can go a week between bowel movements, and as long as the stool is soft, it is not considered constipation. More than a few soft moms report success with breastfeeding or pumping breast milk and giving it to their baby through a tube. One soft mom recently commented on Facebook that her breastfed baby had a milk allergy and she switched to using a soy formula. Soy formula is less constipating than many other baby formulas. Surgery. A cecostomy is a surgery that might be decided upon when all else fails. It is a procedure that is new to soft. Cecostomy is a percutaneous, meaning it goes through the skin, tube into the cecum. See the cecum at the beginning of the large intestine in the slide. An opening through the skin and abdominal wall into the bowel allows doctor-prescribed solutions to be flushed into the colon to moisten and soften the food residue for passage through the colon to the rectum, like a reverse enema. It takes about an hour to work. A laxative will still be needed. Careful attention must be paid to fluids and electrolytes, requiring frequent monitoring by the healthcare provider. It is considered a last resort surgery. A cecostomy is a minimally invasive procedure and requires site care similar to a gastrostomy. Most asked soft question before Miralax with what to do about constipation. Thus, Miralax has likely been prescribed and helped many soft children. Laxatives and fiber with adequate fluids are effective in improving bowel movement frequency unless the constipation is caused by an underlying disorder or a slow colon transit problem. When soft stool is achieved, it is important to continue daily maintenance to prevent reoccurrence of constipation. Constipation is a lifetime concern for those with trisomy 18 and 13. Other moms can be a helpful resource, but remember to talk with your doctor about ideas or suggestions, even those presented in this paper. Any questions, please email me. My email is up there, and it's also available on the website. Thank you so much, Terry, for inviting me. It's an honor to be able to speak to the families this way.
Thank you so much, Anne, for bringing us such valuable and relevant information. A transcript of today's webinar is available for download at the SOFT website. Just go to www.trisomy.org. Again, Anne, thank you not only for this presentation, but for all that you do to serve SOFT and families everywhere dealing with the trisomy diagnosis. To our listeners, thank you so much for joining us. We look forward to you joining us again on another TrisomyTalk.com webinar soon. We appreciate your time. This is Terry Kratzer with TrisomyTalk.com. Bye-bye for now.